On the Scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block in San Diego at ACC 2015 for On the Scene. And my partner in crime over here, Deepak Bhatt, the wrap-up guy who works with me at the end of the day. It is the end of day 2, and this is the wrap-up of what we thought were the most important trials. And Deepak, I listened to the PCSK9 inhibitor trial this morning, OSLER trial, and I was struck by the importance of these results. The mean LDL in those patients was reduced to 45, a crazy low number, and some patients even went below 25. And the outcomes show that, in fact, there is a better outcome in patients that have low LDL. Now, where are we going to go with this?
Yeah, so these are really great results, and it's actually a pooling of a variety of different trials in the evolocumab development program, a PCSK9 inhibitor. And first of all, there's a huge reduction in LDL cholesterol. That's important, though it was already known. But what was novel about this pooled data is the reduction in actual MACE. And that is really exciting. It was about a halving in MACE. Now, in fairness, post-hoc analysis, low number of events, but still really encouraging to see. And also concordant with that is the Odyssey long-term study, where there was also a reduction in MACE with a different PCSK9 inhibitor, alirocumab. So very exciting.
Class effect possibly. The cool thing that they did in this analysis was they took patients who were the lowest LDL level, less than 25, and compared them with the highest levels. I think it was greater than 75, whatever, but fairly high and a great difference, and then looked at neurocognitive outcomes to see if there was a difference, the myelin business, and
right.
Does your brain not work as well? And it turns out there was no difference. So this is all comforting.
Well, I think it's really important, that point, both for this class of medications, but also for the thinking that's out there on the blogosphere that statins make people stupid, right? A lot of patients don't take their statins because they're attributing all sorts of neurocognitive issues to the statins. And here, with very low LDLs, that didn't seem to happen, with the caveat that it's still relatively short duration follow-up and that there are 2 very large cardiovascular outcome trials that are ongoing in this class.
We still need to learn a lot about these, but the good news is that at the front end, it looks very promising.
Absolutely, and we'll see if the large trials confirm this reduction in MACE. I think people are hopeful that it will.
Yeah. Okay. By the way, I like your tie.
Oh,
anyway,
I like yours too.
Thank you. So let's move on. We've got a couple of other things that sort of fit together. Now, yesterday we talked about PROMISE. PROMISE and the CTA and all those crazy things that may or may not be necessary when you're working up a patient. The economic side of that was presented today.
Right.
And then we have the Scott Heart trial, which isn't exactly the same, slightly higher risk patients, but it also asks the question how better or how best to look at patients. What are your thoughts on putting all those together? Because there's a lot of controversy about what this all means.
Sure. So I think overall the trials are concordant and support a role of CT angio in sites that are comfortable doing CT angio in the evaluation of stable chest pain. I thought the economic analysis from PROMISE was very interesting. My own bias was that CT angio was a lot more expensive, but this trial showed it was a little more expensive, but not statistically significantly
not much,
so.
Exactly.
So I think you can't say, oh, no, don't want to do CTA because it's just generating excessive healthcare costs. I think in the right hands, it performs pretty well compared with conventional stress testing.
And for me, I always was worried about the radiation side of the CTA, and it turns out now with modern technology, that really is not an issue any longer.
Agreed, especially if the comparator is NUCs. Now, if the comparator is a stress echo or plain old electrocardiography stress test, that's a bit different.
Yeah, then they get zapped. But
that's
the fact
right.
is, but the fact is, a lot of people do use NUCs,
yes.
And therefore that washes it out.
You're absolutely right.
All right, let's move on, because the third major topic here is transcatheter aortic valve replacement, and
yes.
We have 2 trials now. The PARTNER 1 5-year data,
Right.
Really remarkable. All of those lines that were exactly the same continue to be exactly the same.
Yes.
So surgery versus TAVR in these high-risk patients, moderately high-risk patients, seems to be a wash. This is good news for people that have TAVRs.
Absolutely.
And
I'll take the minimally invasive technique.
Absolutely. Now, the good news also is that the P3 trial, which is the newest
Yes.
Edwards valve, also shows dramatic reduction in CNS events And that is rather extraordinary to me, but when you think about this as a smaller catheter, more user-friendly, maybe that isn't so striking, and also mortality was reduced.
Well, I think it's important, and maybe it was hoped for, maybe it was even expected, but it's great to actually see it. I mean, lower rates of stroke, lower rates of mortality. That means whatever we've observed with TAVR to date, you mentioned the randomized comparison, could only get better with these newer generation TAVR
in fact,
valves.
we're talking about less than half of 1%. So
Yeah,
for
that's pretty low.
Neuro events, and that's very, very low. So mortality is low, neuro events are low, and for the core valve trial, we see the same thing. So it's all good news, and the core valve trial also seems to show that the difference in mortality going forward now at 2 years seems also to be still maintained, that the
Yes.
valve is better than surgery for these high-risk patients.
Yeah, so I think, again, very consistent, all these different data sources. Also, I'd throw in partner B as well, where the 5-year data show durability. That is, if you've got bad AS and you're randomized to medical therapy, you're very likely going to be dead.
Well, the engineers at the front end said these valves will never hold up because they're expanded, everyone handles them, they're compressed and so forth, and at 5 years, the gradients are exactly the same. All good news for TAVR patients.
Very, very good news.
So there you have it, 3 major issues, very important things that have come out of the ACC so far. Candidly, I think the late-breaking clinical trials this year are about as good as we've seen in a long time.
Yeah, the combination of great trials, sunny weather in San Diego, can't beat it.
Thanks, Deepak.